So we deal about 100 to 120 angioplasties a month, and of them maybe 40 to 50 are complex bifurcations. And whenever we see a bifurcation lesions, our main aim is to protect the side branch, which is our main interest of our working. Why? Because most of the MACE or the events that we see in our day-to-day practice on a follow-up are side branch occlusion, especially when there is a left main bifurcation. Circumflex is the most difficult lesion to treat, because once you get a stenosis at the ostium of the circumflex, it is really very hard to treat that, because it's the main branch and you can't do just a left main circumflex stenting without touching the LED ostium. So you have to be very particular in the first go, for the first event only, when the patient comes to you, that you have to treat it adequately and for the life. You shouldn't take the chances the next time. So commonly, as per the European Bifurcation Club guidelines, we take a provisional strategy as our strategy of choice for treating a left main for a non-left main bifurcation, provided the artery is less than 2 mm or maybe 2.25 mm in size, or if the artery is bigger in diameter as well as the length of the lesion is quite long, maybe more than 15 mm, then we rely on the definition criteria, which states that if the arterial diameter is more than 2.75 or 2.5 and the length is more than 10 to 15 mm, you can use a two-stent strategy straight away. So whenever our provisional strategy is there, we try to keep a wire or a balloon in such side branch, and we stent the main branch, and after that we see the results. If the result is adequate, we don't post dilate it, the side branch, or then if there is a flow limitations, then we need to recross and do a bifurcation kissing with a limited size of the balloon, just undersizing the size of the side branch. So the biggest challenge what I face during my side branch stenting is the plaque shift or the longitudinal shifting of the plaque, and when it happens, it's quite a difficult task to deal, because that can lead to side branch occlusion or maybe a good number of MACE in the subsequent time to come. So what we try to do is, first we analyze our side branch quite nicely with our imaging, and we try to use IVUS in a good size vessels. Unless the vessel is a very small area supplying vessel, we don't do imaging, but otherwise we try to use imaging, especially IVUS what we have in house, for just delineating the plaque, the cranial eyebrow sign what we usually call, in which we find streaks of plaque over looking the plaque, and when we do that, we have an idea that whether the side branch will get occluded during our stenting or not. Another important point about side branch occlusion is the presence of the calcium and the lipid plaque around the side branch, and if it is just on the opposite wall, it is a predisposer for side branch occlusion or more of the MACE in the time to come. So whenever we find these kind of plaques, we try to modify the plaque with the cutting balloons and try to have a good bed preparation before we take the main branch stent. And of course, with a two-stent strategy, we try to have a good expansion of our side branch lumen or the ostium especially, so that the stent should expand to the fullest when we take the main branch stent. And whatever strategy we choose, the side branch expansion is a major predictor for long-term outcome. Frequently we have such cases in which there is a stent recoil, or there is a missing of the stent, the side branch ostium, sometimes when we use a two-stent strategy. In this case it's very difficult, so you have to be very particular when you choose your strategy, and you have to be covering the stent as close to the ostium as possible, not to miss and not to overshoot the ostium, because if you have a bigger stent overlapping inside the main branch, again the MACE rates increase. So what we do is we keep our markers well defined before we choose our stents, and for that we define the stents as per their marker and as per their stent and the marker distance wherever they are placed. And whenever we have a clear understanding of our marker and the stent starting, we can have a good result post-op. In this case, stent, the side branch angulation also plays a very important role. If the angulation is very acute, you have to keep more of one stent extra inside the main branch, so that you should not miss the stent, the edge or the lesion length at the ostial part, so that you can cover it quite nicely. If the angle is more than 90, then you gradually have a good experience not to do a straightforward two-stent strategy and try to do a tap technique if required when you stent the main branch, and then you can easily go get away with a single stent strategy also. Stent trackability, the stent mobility as well as the movement of the stent is very important, and for this not only the stent stud thickness but the stent movement is very important, and that depends on the plaque distribution, the distribution of calcium and the orientation of the side branch also. So whenever you have an angulated side branch, you have to be very particular to save that side branch, provided it is a big branch and you are going for a two-stent strategy. For that case, you either choose a culotte technique or you try to do a mini crush, in which you first protect the side branch and then you see for your main branch. Whenever you have a smaller side branch, you try to do a provisional strategy, and in this case you try to choose a stent which have a smaller or a thinner stud thickness, as well as which have a wider intersted stud distance. Regarding the stent design, we try to use nowadays the open cell design, in which the stent stud thickness as well as the interstud distance is quite wide whenever you are trying to protect your side branches, and you try to use a stent which have a good covering of the ostium in terms of a good tactile as well as good radial strength. That will prevent your stent malopposition when you have a difference in the proximal and the distal size of the artery when you have a side branch in between. So you choose a stent which has a good radial strength, so when you do a pot, it gets opposed both inside the proximal edge as well as in the distal edge, as you try to size it as per the distal vessel size. We try to use stents which have a belly to belly connectors, open cell design. Along with that, at least you should have a 6 crown design for up to a 3 mm stent, and maybe a more than 7 or 8 crowns when you are going for a higher size vessel or bigger diameter like 4 or 4.5 or even bigger. Why? Because when you do a pot, the stent studs try to expand, and they may not have an adequate drug delivery at the edges of the vessel wall when you over expand the stent. So you should have a bigger crowns when you are expanding to a bigger size of the maybe a left main or a bigger proximal vessel. The success for a side branch intervention basically relies on the TIMI flow, second the amount of the plaque shift, and third how much is the residual disease which was there to start with and how much you end up when you end your case. So if there is no much difference between the percentage stenosis in the side branch and there is a TIMI free flow, we don't try to catch up or don't try to chase that vessel, and we just end at that level whenever we are doing a provisional strategy. As per the criteria of ARC, the basic long-term result depends on the side branch expansion, the flow as well as the percentage stenosis. Of course, the percentage stenosis is not a well documented marker because you may have a good FFR post-op even when the the side branch looks quite tighter, and it's not a main criteria. But for me, the flow as well as the plaque shift post stenting, the major criteria to predict the outcome of that vessel in the long term follow up. Yes, nowadays we are specifically looking for an open cell design of the stents whenever we are choosing to stent a side branch with a provisional technique, and this helps not only for the primary result but for the long term or the next time when you come up with a restenosis. There is a easy access to your side branch, you can easily pass your wire, and also the stent expansion is quite good because there are not much of the interlinks in between that open cells, and you can have a good result even with just a balloon dilatation, and probably a drug eluting balloon can help you in a case of restenosis when you follow up such patients of a side branch occlusion. So the data what we are looking for improving our outcomes are: first, the type of stent what we use, it has to be open cell. Newer drugs like we use everolimus eluting stents nowadays. Third is the how much is the area what we get after imaging of the artery post stenting. If the area is quite good, probably maybe more than 4 or 4.5 millimeter square in a side branch, you have to have a good result post-op. And finally, the markers of the stent edges, if you have that in terms of your stenting, and you can have a precise stenting in your side branch also, you can have a good result even after doing a 2-stent strategy. Depending on the 2-stent strategy what you choose, what you are familiar with, we here use a double decay crush, or you culotte sometimes, that again you do a double case culotte, but otherwise our strategy of choice is decay crush whenever you are trying to use a upfront 2-stent strategy.